this way, we're going to make it go that way. Or when you're doing your joint play, you're like, it doesn't want to go this way, and I want to make it go that way. So those are the two corrections to the primary listings or lesions. So let's say the person had a posterior TP on the left. I'm going to make the person lay so that basically the lesion side is up. And then if I do the pull move, my middle finger goes on the contralateral side of the spinous process. When I make my correction, it's going to make it go that way, right? Does everybody see that for a pull move? The push move, I'm going to find the vertebra that's involved, and that's where this kind of comes into play. So you can tell, aha, that's the vertebra. Then you're going to put your knuckle on the MPTP complex. So the MPTP complex is the superior articular facet and the transverse process of a corresponding vertebra. And then that's a push, so I'm pushing it this way. So when I do the push, I am perpendicular to the lesion in the same way that it was like with SI stuff, right? So a push is better accomplished with the lunge. So you can kind of go down like that. The pull, which is where you're more like that and you're actually kind of standing up more, you can still do the pull with a lunge, but the pull works a lot better with the kick. So the important thing is to understand what are the two listings, a posteriority and or rotation, which is basically the same thing, right? But we usually talk about the posteriority. So the correction is either do the pull or do the push. And then there are slightly different ways in which you accomplish that by doing the lunge or the kick, depending upon your lesion and so on and so forth. So does everybody kind of get that, at least at this point? All right, so Simon, you want to go ahead and lay down? And why don't you just turn facing me? So again, you're going to get your patient in a basic lumbosacral position. He's on his side. Smooth close to this edge. Traction out, lower ribcage, shoulder ball, and put your head in the center there. So this way he's kind of, in the center of the head thing. He's looking at the ceiling, so he's not going to tend to have that propensity to want to, like, roll over. So bring his leg up. And you can see how that's already kind of up high. So it tells me one of two things. Basically tells me one thing. He has not so much flexibility. So what I'm going to do is rotate your hips this way, a little bit more. Okay. Now you see how his femur is in a more acceptable position, but it allows me still to have the ability to get some space to get locked out, right? So again, when a person, when you set them up initially, you want to have, for the most part, their pelvis perpendicular to the table. If they are Gumby, you want to have them more this way. If they are tight, you want to have them more this way. So that's why I asked him to rotate his hips a little bit more so that I can accommodate that. And then what I'm going to do, find the crest, go down, and that's on what level? All right, so I can drop down one and say, okay, that spinous process feels a little bit more pointed. So that's L5. And then I'm going to start to do my motion stuff with the femur. And then I can use my middle finger because that's my longest one, right? And I can kind of climb up the lumbar spine to say, okay, now I can feel movement in L1, now I can feel movement in L2, now I can feel movement in L3, now I can feel movement in L4, now I can feel movement in L5. So this is your assessment, which you're eventually going to get comfortable enough to do that. Today you probably are like, don't really know what you're doing.
Maybe next week too.
Maybe next week you might have to. So, patient comes in and says, I hurt here, you've palpated them, you've done muscle tests, orthopedic tests, dermatonal, this or that. You kind of determine this is the lesion. It's at L2, L3. It's at L3, L4. It's at L4, L5. It's at L5, S1, right? So you kind of know where it is you need to go. And then this is your way to figure out how to get there. And then the correction, as I mentioned, is twofold. One is to use the pull. I will describe that first. I'm going to find that spinous process, and I'm going to use my index finger to kind of hook on it, right? So I'm hooking on it. I'm using my forearm on his ilium. So I can do a lunge this way, and I'm using this hand to kind of go like this, right? Which is pulling the vertebra this way and making the posteriority correct. You can also use the kick, which looks more like this, to help correct the same thing. You want to try to do this as much as possible, although it's a little bit less mechanically possible because you're standing up more than down this way. All right, and then to use the push, I'm going to use the palmar surface of my first knuckle. So I find the SP that I want to correct, and my hand just slides in. It's right there, and then you can see how I'm perpendicular to the spinous, or to the vertebra. And then down while I push. I'll just do it on the other side so we even them out. Other people over there can kind of see it. Straighten out your lower leg. Top leg comes up. Rotate a little bit more this way. Lower rib cage, shoulder ball. All right. So I'm starting to feel forward movement. Sometimes when you do this, you'll feel a little release. That's typically like low-lying fruit or palpatory releases, which really usually aren't what needs to correct, although sometimes that's all you get. Maybe that's all you really needed, because you're still using a fair amount of focus kind of pressure. So the first one would be the lunge associated with the pull. My middle finger's on the contralateral side of the spinous process, really, so it's the side of the spinous process that's away from me. My forearm is on the ilium, and then I come down like that. The kick, when I use the kick, I want to put my knee more on his femur, right, because that keeps him in a little bit of flexion. Same kind of thing, and like that. And then the push, use my palmar surface of my knuckle on the MPTP complex. I have to be perpendicular pretty much to the femur, right? Nice little rock. And then down like that. Okay, so those are the different corrections for lumbar spine and the different kind of venues. Or not venues necessarily, but styles. So I understand that, one of you, when you come into the test, you might be able to do the kick or the lunge better. So that's okay as a variance that you can choose. But you won't necessarily get to pick SI, sacrum, or push or pull unless, because you can do the push has to be kind of a lunge. If you can't do the lunge, then I would probably say, okay, then you do the pull. And that way you have to do the kick. So that you can still, and the TAs will be able to accommodate what is it you're trying to do so that we can evaluate whether you're doing it correctly or not. One of the mistakes that I see some people do, turn this side again, when they try to do the kick, they try to do the lunge. So this leg bends like that. And this leg doesn't do anything but come down like I'm trying to do the lunge. So I can't even do it really because it's wrong. But I've seen students manage to do it pretty wrong, pretty good. So again, depending on what technique that you're using, you have the mechanics of that technique to utilize. All right, any questions about the lumbar? Okay, practice that up for a little bit, and then we're going to do